All right, good afternoon, everyone. Thank you guys for joining this call on your lunch break. We'll go ahead and get started on time so that way we can end this call on time. I just wanted to provide a brief introduction. I'm Brandy Bourgeois. I serve as the HCCN project manager. Also in the room with me is Chris Obonsumwa, who's our HIT director, Susie Hutchinson, who is our practice management director, Shannon Robertson, who is our quality director, and Amy Prime, who's our data analyst. Today we have a really good presentation for you all with regards to the Azara software that I'm sure you are all quite familiar with, and some centers maybe more than others. What we're hoping today is that this presentation will kind of provide you an overview of the software and really drive home the message of how important this Azara software is and can be. Hopefully by this time, all of your centers have received the contractual documents to get this Azara software moving. So we hope as a result of this, we'll start to get the rest of the contract information in from all the health centers whom we haven't received your information from. Just some logistics really quick. Chris from Azara is going to host the presentation, and throughout his presentation, we'll kind of pause time for some questions that may come in through the chat box or even those that may raise their hand. So in order to ask a question via the phone, if you go in under the attendees tab, there's an actual hand. If you click the hand, it'll raise your hand and I can unmute your line. But if you feel more comfortable just typing in your question, there's a chat box that we'll be monitoring throughout the webinar that you can type in your question, and we'll address those as we pause during the presentation. So at this time, I'll go ahead and turn it over to Chris Neal, who serves as the Director of National Accounts from Azara Healthcare, and he'll provide an overview of the agenda for today and start with his presentation.
Thank you very much. And can you hear me okay?
Yep, we hear you.
Great. Hello, everyone. My name is Chris Neal. I'm the National Director of Accounts at Azara Healthcare. Appreciate the introduction and the setup. This has been very exciting to move through the selection process with many of you that took part in that process, and we're excited to expose you today to some additional background and context of the solution, where it came from, some case studies. I further want to get into some concrete details on what the implementation cycle looks like to set some expectations around center resources that are needed during that part of the process, and give you a really good level of insight into what that looks like from your perspective. And then I will get into the demonstration, show the suite of functionality that's provided within our technology for you to pick and choose what works and what is aligned with your internal data strategies at each of the respective health centers that are a part of this. So again, to sort of go back a little bit, we began as a consulting project in Massachusetts with the Mass League, which is the primary care association here in Massachusetts. And the project really set out to have, twofold success criteria. One was to be able to deliver a robust insight into population health for all participating health centers, be able to provide them with insight into their performance, how they were performing, areas where they could or needed to improve, as well as the second piece to it, which was the aggregated common data platform. So having a EHR agnostic platform that we were able to pull in data from multiple different types of EHRs into one consolidated platform so that the health centers could form a unified front and represent themselves collectively rather than health centers being responsible for one-off data programs and IT projects. And if you fast forward a few years, we started to integrate different types of data as it relates to admit, discharge, and transfer, data to help you track and monitor patients in and out of the ER. We also started to integrate payer data, starting with enrollment and moving on to claims. which really gave you that total 360-degree view of patient care. And we realized the applicability and value of this technology, not only to the constituents here in Massachusetts, but really to community health across the country. And around 2011 timeframe, Azara spawned off from that consulting company to do just that. At this point, we're in 1 in 5 community health centers across the country. I think there are 8 that are up and running in Louisiana at this time. We have key relationships with dozens of PCAs and networks, and it's really excited to finally have this call and get working with you and introduce ourselves to those who aren't quite familiar yet with what it is that we provide, so we can discuss its implications and value and what it means to you. I think the key focus of this slide is that we are helping our networks and centers that use us to operate from a position of strength. Joe Perley, the CEO of the Primary Care Association in Missouri, always says you have to own your data to be able to navigate your future effectively. And that's really what we're providing, is visual insight into your data from a population health perspective, all the way down to the granular insight of patient details within one single technology foundation or infrastructure. And I think as we go through the system and as I get into the demo environment, it's important for folks on the phone to sort of think about this from wearing multiple hats. What might this mean for a user at the network level? What might this mean for users at the health center level? And not just QI folks, but clinicians, MAs, LPNs, leveraging the data that you have access to in a really easy format. How does that align with your internal data strategy, and what are the implications across the entire data food chain, so to speak? And I think that not only to, not to overwhelm you with the magnitude of what this project can do, but just to help you understand a little bit about our vision and where this can all go once the foundational implementation has taken place. So what you're seeing on your screen is a representation of the different types of external resources that we can integrate with into your clinical data. So we are, showing you Drives. That stands for Data Reporting and Visualization System. That's represented as the green gear in the center of your screen. We are pulling data in on a nightly basis from all of our community health center clients across the country, represented as the black gear on top of your screen. So initially, we'll pull all of your historical data, or mostly about 3 years, and then for things like colorectal cancer screening, we can go back further. But then going forward on a nightly basis, it's just very small jobs that are running in the middle of the night to be able to provide us with the data elements that we need from your EHR to be able to provide the reports that we allow you or enable you access to via the web. And those reports are what I'm going to show to you in the demo environment. But when you're just talking about the clinical data from the health center, it's only giving you one aspect of total care that's provided to the patient by the system. So what we've started to do in other states and have had some fantastic success stories are things like including hospital admit, discharge, and transfer data for our transitions of care modules. You can track and monitor patients in and out of the ER, lower readmission rates, have the appropriate follow-up, et cetera, et cetera. Other things that we're able to do are to reduce the number of data requests to participating members by the network, because we can deliver that data centrally via this centralized data warehouse. The network is empowered to respond to grant initiatives much more seamlessly and easily without bothering center resources. We can push data to things like immunization registries, public health initiatives, and then last but not least, as we go around the wheel here, we've included health plan data. Being able to give you, the ingested enrollment data, for example, with your clinical data so that you can see the members that a plan is attributing to you and be able to match that up against the patients that you're actually collecting data on in the EHR, and being able to put together a strategic outreach and engagement for those members who you're not seeing. So very, very exciting things done on a total medical expense and ingestion of enrollment data for eligibility, utilization, cost, and risk analysis. A couple of case studies here, and I'm not going to go into any of these in great detail, but I do think it's important for the folks on the phone to take a look at the left-hand side of my screen. And a lot of this work needs to be done in conjunction with the HCCN and PCA, with other network entities that are helping to drive this forward in Louisiana, so that everyone's in alignment with their goals for data usage and how you're going to maximize the investments that you've made, whether it be to support an IPA, whether it respond to grant opportunities, whether it to be the core foundation of QI initiatives that you want to run statewide, or all of the above. But it's important for us to understand, as this takes off, what are the capacities for which you want to use the system, both as a network and an individual center. Getting aligned on the same page on that is a really important piece to all of this. The example that I've given here is with the New York Primary Care Association, also known as Chicanes. What they did was they put us live at 5 centers in the New York City area and started to put together a case study that helped them to respond to a grant initiative with the CDC. This was for breast cancer, cervical cancer, and colorectal cancer screening by location. And the PCA said, not only is this going to provide a common data platform for those 3 measures, but it has this additional suite of functionality that will really help our members now and into the future. And they secured a $14 million grant that enabled us to really, in a prolific way, expand our implementations to the rest of the health centers in the state. And really what we're doing here, and the key concept, is putting a sustainable IT infrastructure in place here to minimize future investments in IT. So it's not an IT project, it's really helping you to enable those dollars that flow towards you to go more directly towards the quality of care that's being delivered, because this IT infrastructure is so robust that we're going to be setting up initially. And I think, I have a few individual health centers here, both large and small, and on different types of EHRs. And let's see, Bedford-Stuyy in the lower left is New York, and the other, Bedford-Stuyy and Lutheran are in New York, and Tiburcio-Vasquez is in California. But these are individual health centers that established upfront their goals for data usage. We've found a strong correlation between the level of sophistication of a health center and the frequency with which they visit the data. So what these health centers have done in particular on the screen here is establishing the goals for data usage, identify measures that everyone cares about and can rally around, and then run PDSA cycles to as interventions for the measures that they want to improve on. And then really what you're seeing out of our system is the demonstrable results for those quality improvement efforts, and then equipping you with a position of power as you go to payment reform negotiation, as you're responding to other grant opportunities and finding further opportunities to demonstrate the value of care that you deliver at each of your FQHCs across Louisiana. I'm going to speak to the setup and implementation process, and then from there I think we'll just jump into the demo, sort of where the most interesting material is anyway, but we do have a very much differentiated process to set up this technology, and I think it's important to talk about and help everyone on the phone today understand what that process looks like. So as was mentioned earlier, you have the contracts in hand to go ahead and execute that piece of the process. Once those contracts come in, you'll hear from me, and we will work through the connectivity process together to help us gain access to the data within your EHR. Now, it's sort of dependent upon what type of EHR you have for how exactly we do that, but ultimately what we're looking for is access to the data so that we can start our implementation process and do all of the mapping of your data, okay? And that's a really key piece of all of this. There's no shortcuts. It's the most arduous piece to making a reporting technology work, and it's done all on the shoulders of Azara resources. So once we establish connectivity and gain access to the data, we come visit you for a day where we do an EHR walkthrough, we meet your team, and we go ahead and start setting expectations for the next 8 weeks. And so what that looks like is not that you're on ECW or NextGen or Athena, but rather how do you have those EHRs configured? Do you have your own custom fields made, your custom templates made, and your custom workflows? The answer is probably yes to all of the above. Do you have 30 places to enter smoking cessation? Right, and that's a big one that most folks have a really struggle with when trying to get accurate reporting representations, because providers are entering data in the system all over the map. And so we really take control of that process to work with you and make sure that we have a comprehensive approach to our queries to make sure that we've mapped the data accurately and in a comprehensive fashion. Towards the end of that 8-week process, we include some clinician time. And that's for data validation, and that works for twofold value. One, validated data is always better data. And two, when clinicians take part in the setup of a technology, they tend to have a much better or much higher level of confidence in the accuracy of the data at go live. And so putting this process together, all the components that I just mentioned, really leads to a set of data that you can trust, that people have a high level of confidence in, and really produces accurate representations of the quality of care being delivered by the center. Now, after that 8-week process, you go live and we begin our adoption phase, which is to say, we work with you to understand what your goals are, and we put an adoption plan together. That's a 6-week menu of workshops that we engage with you on to make sure that we've covered all the bases in terms of training and adoption. The suite of functionality that I'm going to show you in a moment, not one single health center uses everything. So it's really important for us to understand what are the pieces of functionality of our suite that are really important to you and that are really going to help you maximize your investment. And so, yeah, so that's the 6-week adoption phase. And then it's really our work with the PCA and HCCN, Chris and his team, and understanding how it is that we can support the network initiatives overall to bring the data and its importance well beyond just your 4 walls. And really, how that looks from a technology perspective or a architecture perspective is that we're pulling all the data into a common data platform. And from there, we can start to integrate other types of data, but you always have the reporting interface via the web within your center. And there's always unlimited end user access. So we want everyone on your staff who can derive value from accessing the data to have their own username and passwords and be in the system using it regularly to maximize their benefit. So that's really the high-level overview. I know it was quite a quite a mouthful, a lot of information, but hopefully that gives you a little bit of idea in terms of setup and how we take the approach towards our technology. Before I jump over into the demo environment, probably makes sense at this point to pause and Brandy, you can let me know if anybody's chimed in with questions, and if not, I'll toggle over to the demo environment.
We just had one question come in. It's more of a logistical question, but just so that everybody know, we'll get the presentation from Chris and the recording of this webinar, and it'll all be placed on our HCCN portal via our LPCA website, so you'll have access to all this information after. But if you do have a question, remember to jot that down in the questions tab, or you can click your hand and raise your hand, and I'll unmute your line, and you can ask Chris the question verbally. But Chris, at this time, I don't see any questions from attendees, so you can go ahead and jump.
All right. So I am going to log into the demo environment. And I'll just ask you to verify for me that you can see my homepage.
Yeah, we can. And Chris, we actually did get a question that came in if we want to talk about it real quick.
All right, what was it?
I'm trying to figure it out. Hold on, Chris.
Sure, no problem.
So it was a question about one of our centers actually already has access to Azara through another project. So we can deal with that one
Sure.
off specific. So go ahead and jump into the demo.
Yeah, no, and any folks who already, have Drive set up in their system, probably makes sense to take a more deeper granular dive, not on just an intro call listening to me talk for, another hour, but have a more in-depth conversation of how exactly we can help you. So feel free to reach out to me on the side or through LPCA so we can talk about how to make sure that your questions are addressed. So right now I'm in Azara Drives, and I'm on the Drives homepage. And I'm sort of going to break this up into a variety. Well, I'm going to take our menu of functionality and sort of break this apart into manageable bite-sized chunks. There is a ton in the system out of the box. We have over 350 measures, a variety of measure categories. We're certified on meaningful use CQMs. We have patient visit planning, referrals, drill down, all sorts of things. And so to try not to overwhelm you too much, I'm going to go through this piece by piece, and hopefully we can get through quite a bit of the system today, at least a good overview. So this is the home page, and from my home page, the first thing that I want to take you to is the most used report by our end users. Okay, it's the care gaps report, or the huddle report used for patient visit planning in the morning huddles. And so I'm going to click on visit planning here just to show you how to navigate. And what this is doing is it's pulling data from the EPM and EHR systems, and it's only the actionable data that can be discussed to prepare for the patients that are coming in for the day. Identify any bottlenecks in the shift, prepare any translation services so you're not scrambling while the patient's waiting. Delegate tasks to the MAs or LPNs so that the provider can spend the most amount of quality time with these patients. So I ran the report. It's by provider last name. So I just clicked on A to see Dr. Augustine, and we can see 8 scheduled appointments for the day. And as I scroll down, you're starting to see data on each of these patients, but in a very, very concise way, so as not to have those morning huddles get bogged down in something bigger than they need to be. So just going through this really quickly, you have the time, the day, the visit reason listed across the top bar here. You have a bunch of information on the patient, including medical record number and date of birth. You have some SOGI elements, preferred language, which again is helpful for setting up of translation services. You're seeing risk stratification. I move over to the right, you're seeing PCP, payer, and the care manager called out here. Again, keep in mind this is all dummy data, but we did want to make sure that this populates well. So you're seeing the patient diagnosis, or in this case, a whole series of diagnoses for Damaris here. Risk factors here, BMI and tobacco user. You'll also see things like severe mental illness and psychosis, substance abuse and dependency. You'll even see if it's a female who happens to be pregnant listed here as well, even though that's not technically a risk factor, just so that you have that information going into the visit. Below that, we have our social determinants of health. For those of you who are using the functionality for Prepare in your EHR, we will include that as part of our implementation to draw those data elements so that you can have access to our Prepare registry. For others of you who are not, we will just be collecting the appropriate SDOH measures that that would apply to you. Now we're seeing the alerts or all of the gaps in care. I'm going to see if I can scroll down a little bit more and find a better list. I guess this is okay. So you're seeing all the care gaps, A1C, gonorrhea, LDL, audit, violence screening, et cetera, et cetera. You're seeing the messages. So what's missing, what's overdue. You're seeing the most recent date, and you're seeing the most recent results. One of the main reasons that this is such a unique report and is so helpful and used so much by our end users are because the alerts are tied to underlying measure logic. So we're going to work with you during the implementation to understand what your goals are, what measures you really want to focus on, and then we can turn on the appropriate alerts. So because that's the easiest way to move the meter on those measures, because as you close these gaps in care, they will then be closed in the EHR, and the measures will start to move. It's, like I said, the best way to sort of move the meter on these measures. Other things that are helpful here, if you see mammogram, oftentimes that, if not always, takes place outside of the health center organization. So this is just showing you if it's been taken care of, if it was completed, it should be closed in the EHR, just to have all that information to close the loop on that particular patient's care. The other things that we customize here are the range of things. So we use national guidelines for each of these alerts or gaps in care. But if you want to tighten those guidelines to parameters that are a little bit tighter, if you want something to happen every 6 months rather than annually, you can go ahead and have us configure it during the implementation so that it's set up to meet your needs. You can also see here open referrals without a result. The two items here that I'm going to speak to that are optional are the referrals module and risk stratification. Okay, so I just want to let you know we have a referrals module that sort of tracks and helps you to manage and report on the entire life cycle of referrals within your EHR. One component of that module is to list the open referrals without a result on this patient visit planning report. The other thing that I mentioned that was optional is the risk stratification. And the reason it's optional is because we can do it in a couple of different ways. If you're assigning risk to your patients, if you're assigning a risk score to your patients within the EHR, we can map to that and have whatever shows up in this report match what you're already doing in your EHR. That's the easy way to do it. Other ways that we can do it is a custom risk algorithm. So we can bucket your patients into low, moderate, or high risk based on a variety of criteria that you can customize with us during a 5-week iterative review cycle of that custom risk algorithm that we can then code to. Another one, which is sort of easier than doing that center by center, is to put together a universal risk algorithm that can be applied to the entire patient population that's seen by FQHCs in Louisiana. That actually makes a whole lot of sense so that everyone is continuing the way every other piece of functionality operates in our system to look at their patient population from the exact same lens. So low means low, moderate means moderate, and high means high. So we can do that either of those ways. We also have integrated the Johns Hopkins risk algorithm, which is another option that becomes a lot more powerful if you have the claims data integrated in with this. So not being quite to that phase yet in Louisiana doesn't exactly make sense to go through that in too much more detail, but I did want to make sure that everyone understands we have a variety of options when it comes to assigning risk to your patient population. And when you see it show up in this patient visit planning report, your care coordinator can also run this daily visit planning report by risk. So if you want to immediately see all of your high-risk patients that are coming in for the day so that you can form a strategy around your approach to that particular patient list, you may do so. And then last but not least, if I scroll up here, there's a medical record number entry field where, depending upon your level of open access, I can go ahead and enter medical record number, a medical record number, or multiple medical record numbers, and it will regenerate this report with information on those patients that surprised you for the day. So again, unlimited end user access to be able to see this type of data and prepare for the patients that are coming in for the day. I want to show you next report pertaining to a more longitudinal approach to how you can visualize patient level detail in our care management passport. So the visit planning report is really giving you that snapshot and what can be done today and what are those gaps that can be closed to leverage today's visit. The care management passport takes more of an approach to say what's been happening with the patient and help the patient to more easily navigate around different parts of your organization as appropriate. So we're seeing the same information on the patient as we saw on the previous screen, but now we're not just looking at, what their open items are for today. We're looking at their last 10 assessments, descriptions, codes, the last 10 active problems. As I scroll down further, we're seeing encounters. You can see the provider, the type of encounter, and the reason. And then we wanted to be able to show you some trending over time for some key metrics. So BMI, systolic, diastolic, LDL, A1C, and PHQ-9. Now this is sort of providing you the results along a timeline here, and it's distributed evenly based on how far apart the visits were. And we can include up to 5 points on these lines to be able to see that trending summary. Assuming you may have find important to see the next 5 appointments, we do have the next 5. Usually folks use 2 to 3. That is helpful to have that visual into an insight into what's happening next with the patient. Of course, the social determinants of health are exactly what is going to show up in the patient visit planning report, as are the alerts. We just wanted to make sure that all of the gaps in care show up on the summary as well. And as I scroll down, you can see open referrals without a result, allergies, medications. You can also see IP and OP usage if we are ingesting ADT data from either an affiliated hospital or an HIE. Those are the types of things that you can do to continue to have the insight into the whole continuity of care for this patient. So that's the care management passport and the patient visit planning report. 2 really important pieces of functionality that I wanted to make sure people had exposure to. And I'll just sort of take a pause here and see if there are any questions, since I can't see the...
Yeah. Hey, Chris, this is Brandy. We did have a question come in, and the question is, can care gap measures be set up at an individual patient level, at a group patient level, a satellite level, and an organizational level?
Yes. Yep. So I'm going to sort of show you via the drill down and measure analyzer how it will look like to be able to slice and dice in the manner that you just described. Anything else?
That's it for now.
Okay, great. Okay, so I'm going to go into the drill down functionality, or what we call the measure analyzer. Okay, and really what this enables you to do is look at things across an entire population health perspective, drilling down all the way down into specific patient lists, provider lists, and ultimately, obviously, the patient level detail with a bunch of different slicing and dicing operations to be able to do along the way. So we're going to start here from my home page. And I'll just note here that my homepage has a set of measures on it that you can see that happen to pertain to adult diabetes. You can have whatever set of measures you want on your homepage in a customized fashion. A lot of our clients create custom scorecards where they focus on a particular set of, 5 to 7 measures that they want everyone to visit frequently and have a very good understanding on how they're doing, how they're performing. Use the system to find areas where they can or need to improve, areas for opportunity for improvement in standardizing the quality of care across the entire organization, but not just the entire organization, but also an entire network as well. So you can identify, who of my peers are also on the same EHR and how are they producing those numbers and how can we collaborate with one another to be as effective as possible. So I'm going to start to drill in here. Again, here's my custom set of measures on my homepage, but you can pick whichever you want on your homepage from the 300-400 measures that we have available out of the box. Rather than click on any of these hyperlinks from the home screen, I'm going to click on Full Report to show you more about what's happening behind those numbers. So we're seeing the measures from my homepage, but now we're seeing the targets. All right, with the stoplight functionality, we can see the results that were from my homepage that are obviously, just based on the numerator and the denominator. And we can also see any exclusions. Now, when I look over here on the left-hand side of my screen, there are all these I buttons. This is a system of a very high level of transparency and a very high level of accountability. So we want to make sure that everyone understands exactly what it is that they're looking at from a measure documentation perspective, right? So when we build measures, we build them universally and apply them across all the users in the country. So UDS looks exactly the same for those folks that are running them in our system out of Massachusetts versus Hawaii, for that matter. And one of the key components to making that all work is to have a very clear definition around the measure documentation, the definition of the numerator, definition of the denominator, any exclusions, links to technical specifications or other resources if the users still have questions. But having those all over the system is very helpful, especially when you have measure names that are very similar to one another, but are tweaked ever so slightly in their look back times or qualifications for exclusions and things like that. So I just wanted to make sure that everybody understands that and its transparency from this view and helping our clients to understand what exactly it is that they're looking at. I'm going to give you another display option here that's going to give you an interesting view of what this can look like within your health center if you want to look at it by locations, for example. Okay, so this scroll down that I'm going through right now has a lot of options here, but I'm just going to try to stick to those that are pertinent for today's discussion. I'll click on crosstab. And what this is going to enable you to do is look at all of the locations that you have, the performance of each of the locations within the current period for each of the measures that I had on my homepage. So now my measures aren't, down the left-hand side. We're seeing all the locations that are involved in my health center, the measures across the top and the performance of each location. If I want to look at shorter, PDSA cycles, I can change the period type to monthly, quarterly, trailing year, or yearly. I can do this from a rendering provider perspective or a usual provider perspective. So depending upon the level of open access, that can have a pretty dramatic impact on the numbers. If I want to look at this further granularly by providers, I can go ahead and do that. So for meaningful use, this is extremely helpful. I have my providers down the left-hand side of my screen here. I have the measures across the top, and I have the performance of each of the providers within the current period, which tends to be very, very helpful. And then if you want to look at more like the aggregated view of things, I can put this into centers view. Now, this demo environment consists of 3 fictitious health centers, so I've just sort of rolled everyone up into Access Community Health, Family Health Center, and Neighborhood Health. So at your most aggregated level, you'll be able to see how you're performing amongst your peers for the appropriate level of detail that you've decided to collaborate on as a network. So I am going to go back up to no grouping. And we are going to drill in on diabetes eye exam. So I'm going to click on diabetes eye exam. And I really want to keep I want you to keep in mind that as I go through this functionality is applicable to all of the measures that are within the system. I'm just showing you the example through the lens of diabetes eye exam. So what we're looking at here is a trend line over time from February 2017 to trailing year February 2018. So like this 12-month look back. If you want to change that, you can, which is a really good idea as you're running UDS. Earlier in the year, folks like to look at 12 months trailing. Towards the end of the year, they want accurate representations of what took place during the year, so they'll run it year to date. And then, of course, same other filter functionality that I mentioned before. A lot of this doesn't make a whole lot of sense to do at this aggregated level, but I do want to show you we have this whole level of flexibility within just this framework of uniformity that you're seeing within the components here of the filter bar. Now, we're seeing the trend line over time from 58% to 70%. As I scroll over this, you'll be able to see the numerators and denominators as they're interacting with one another. You can see the primary target and secondary target represented by the green and orange lines here. And as I scroll down is when it starts to get very, very interesting, because we're seeing the 3 health centers that I mentioned in this demo environment, how they're performing amongst one another. So this becomes really, really cool when you have a network of, well, currently your network has 8 or 9 health centers that are up and running in this. As you come together and form a group, a QI committee, you can decide what exactly is appropriate to look at and which measures you want to focus on. You can identify who's performing at levels that everyone else can learn from. So you're seeing access community health on the left-hand side of this graph, family health in the center, neighborhood health center on the right. And if I am a member of Access Community Health staff, I can start to dive into my numbers further. So I want to be very clear when I say Health Center 2 staff cannot see Health Center 1's data. That is very much walled up. You can sort of see high-level numerators and denominators, but you cannot see any further into your peers' data. It is very much protected. But if I'm a member of Access Community Health, I have the credentials to do so, I can click on my health center and I can start to see a trend line over time for just my health center. Okay, so this is no longer the network, this is just Access Community Health. And if you wanted to group your peers in certain ways around EHRs, EHR types, things like that, you can of course go ahead and do so in an ad hoc manner within this filter bar. So now I'm seeing diabetes eye exam trailing year February 2017 to trailing year February 2018 for just Access Community Health. And if I want to know who of my patients have been diagnosed with diabetes who have not had their diabetic eye exam within the qualifying period, all I have to do is click on detail list. And it is going to bring me directly to that list of patients that I need to have my active outreach and engagement to pull them in to improve my numbers around this particular measure. I have the address, I have the phone number, I have the email, I can see whether or not they're in the denominator, all of the information that I need to go ahead and strategically form a plan around this particular set of patients. Most recent provider, most recent location, next appointment information, whether or not they're in the numerator, most recent diagnosis date, and most recent eye exam date. Again, if I have the credentials to do so, I can export this into Excel. So for any of you who may be more sophisticated with Excel or comfortable with that type of functionality, you can of course go ahead and do that. If you want to save this to your favorites, I can just name this report and it'll show up on my homepage. So even though it's super easy to get to, just always trying to make sure it's as easy as possible on our clients to get there even faster. Now, I'm going to take one step back, if you don't mind, and go back up to the sort of aggregated, the center level approach. So I'm in Access Community Health. I can see that I've gone from 53% to 72%. My patient level details were here, but I want to scroll down and see a little bit more about what's going on with this measure, and I want to do it by location. Okay, so now we're looking at these groupings by Main Street office location, 70 Blanchard Road location, 1400 Cambridge Street location. And the reason why this is really helpful is because oftentimes we'll see locations start to trail off towards the right of this graph. What this will enable you to do is allocate some resources and taking a deeper dive and analysis into what's going on behind those numbers at those particular locations. Sometimes we see training issues, sometimes it's staff turnover, sometimes rogue workflows are developing, and it's all good, but having the ability to see the data here will help you target how to make those improvements and standardizations and accuracy, and still accuracy and confidence in the data that's being pulled out through our reporting and analytics solution. If you're not a graphical person, as much of a numerical value person, I can always show the table behind this. So we can always see the locations, the results, the numerator, and the denominator. If I scroll up and I want to show the tables behind this, we're now seeing the groupings by time period, trailing year 218 to trailing year 517, 517 to 218, and we're seeing the result numerator and the denominator at this level as well. So you can always transform the visuals into what works best for you as a user. I'm going to go back to the column, and we're going to click on a single location. And within this location, I can go ahead and put together provider teams. I can do that ad hoc, or I can have them pre-configured into the system. So we're seeing, green team, orange team, Dr. Augustine, Dr. Black, Dr. Crowley, et cetera, et cetera. And we're now looking at this one single location trend over time, so 59% to 78%. The location that we're looking at, since it's at 78%, we're seeing that being a better result than the best center, than the network average overall, and the center average that we've drilled into. And as I scroll down, we're seeing the providers' performance amongst one another. A lot of folks like to put this up into staff rooms, form different incentive programs within their organizations to encourage their providers to focus on specific measures and visit these reports regularly. And now we're seeing Dr. Smith on the left side, we're seeing Dr. Fritz on the right side, with all of the numerator and denominator as I scroll over, which is very important because you may have a provider performing at 100%, but if they have one or two in the denominator, that's not always, or that's just not that helpful. So I can click on the table view at this point, and it's going to show us who has the highest denominator, patients with diabetes. I can sort by this to bring the highest to the top, and that's essentially going to find us that low-hanging fruit. In this case, everybody's doing very, very well, so it's not necessarily applicable. But we're seeing Francine Winslow with 269 patients in the denominator and operating at 77%. If we want to look at Dr. Winslow, or if Francine wants to come in and visit this report herself, simply click on the name, and it's now going to show you a trend line over time for just the performance of this one single provider. And now as I scroll down, the grouping is by race, but I think, we'll just revisit the concept that at any point in this drill down, once I have the credentials to do so and CPHI within my center, I can always click on the detail list. So this is going to be the patients under Dr. Winslow who have not had their eye exam within the qualifying period after having been diagnosed with diabetes. So while that list was fairly simple to pull up, what if you wanted to add an additional element of risk or a comorbidity over the top of this data? You can always do that, and you can continue to go into this filter functionality further. So what I'd mentioned was looking at a comorbidity. So if I want to do patient diagnosis, I can do that. And we'll look up patient diagnosis for, hypertension. And we can update this list. And we've just added that filter over the top of this patient list. So at our core, what we've done within this drill down is taken the measure diabetes eye exam. We've drilled down into a single health center within a network. We've drilled down on a single location within that health center. We've then drilled down into a single provider. We're looking at all of the diabetic patients underneath that specific provider who have not had their eye exam within the qualifying period and have also been diagnosed with hypertension. So it's a very sophisticated level of detail that we've gotten to here, but in a very sort of user-friendly way. And as I mentioned earlier, this functionality is applicable to all of the measures that are available in the system. And if I sort of just take this high-level approach of showing you UDS, PCMH, meaningful use, HEDIS, Healthy People 2020, phase, GIPRA, Million Hearts. There's a ton of measures and reports in here that I will not be able to, of course, get to all today, but I did want to make it very clear after having gone through the, hopefully it wasn't too painful, but a lot of folks going through a lot of scrambling during UDS season. So what we provide out of the box as part of our, of course, validated core wheelhouse of our implementation is tables 3A, 3B, 4, 5, 6A, 6B, and 7. We have the CQMs listed here from 2016. We have the patients by zip code. All of this is at the fingertips of our users and encouraged to be visited regularly. And I think, also in discussing UDS, it's important to know that we we evolve with the needs of, and requirements of community health. So what that means is that when UDS comes out with their PAL document and that starts to evolve over the course of the year, we go ahead and code our system to meet the requirements of the PAL document. When that's finalized, we have a release within a few weeks, and we have the data ready for visitation well ahead of time from that submission date. So, in other words, if they finalize the PAL document in August, then by September, everyone can be in there looking at the most updated requirements for UDS. And that tends to be very, very helpful, not just for UDS, but for the entire spectrum of measures that you're being held responsible for. Any questions?
Yeah, Chris, we did get a few in. One of them, I think I can go ahead and take a stab at addressing, was can care gaps, we did that one. Is Azara's care gaps going to reflect the current care gap that's in the EHR? And that is, the answer is yes. So just so you know, Azara is just an overlay data platform on your EHR system. So your Azara platform will reflect everything that's inputted in your EHR system. Right, Chris?
Yeah. Yes, that's correct. I think that, just to put a finer line on it, how your EHR may be collecting and reporting on a few measures that they have available, and that measure logic, we don't touch any of that. We just go specifically on the gaps in care and the data elements that we retrieve as we go through that mapping and data validation process. So yeah, so the answer is yes. If you want to continue the same guidelines that you have currently configured in your EHR, then we'll work with you just to match those. But, all in all, the gaps that you see within our system will match or code to the underlying measure logic for each of the measures that you want to focus on, and then the reports will accurately reflect, the status of those data elements in your EHR.
All right. And then the next question we have, I think, is more around like viewing permissions and security measures. So the question is, can we create a patient roster for different users? For example, case managers can only have access to their patients and not other clinic patients.
Currently, the way the system's set up is you either have access or the credentials to see PHI or you don't, and that's universally applied within your organization, but I can go ahead and have a chat to see if that's changing anytime soon.
All right. And the second piece to that was for privacy measures, if there's a difference where you can show only certain employees certain things as opposed to others.
Yeah, I mean, it's role-based access. So overall, you will have your options through the super user, whoever you have configured as your admin, to be able to not only apply specific rights to certain users, but also be able to run an audit to be able to see what users are logging into the system, what frequency they're running reports on, and what reports specifically they're running. So that really helps from an auditing perspective, give you the visual insight that you need, and also that's just helping you to track adoption as well. So it's a helpful feature for a number of reasons.
Hey, Chris, we have one final question. I think it's
Sure.
more of a broader question as to how Azara integrates with the EHR systems. So is Azara completely separate from the EHR, or is it a software that is implemented into the current EHR system?
So Azara is a completely separate system. We have a set of queries that runs on your database on a nightly basis in the middle of the night so as not to affect, production. We have send that updated, nightly queries for incremental data, SFTP shipped over to our centralized data warehouse where we unpackage it, sort it, organize it, and apply it to our data set so that you can see the updated reports on a daily basis. As far as workflows go, we do not overlap with EHR workflows. If your EHR happens to go down for a day, our patient visit planning report has been very helpful in helping folks close those gaps and being there for you in emergency situations. But there's really no workflow where there's overlap and folks needing to be in the two systems at once. So really what our system is meant to do is to show accurate reflections of what's being captured in your EHR. We're not trying to be an EHR or a secondary system where folks have to be burdened with entering data into.
Right. And I think just the important piece to note is that when employees of the health centers enter data into the EHR system, it's indirectly entering into the Azara system. So there's no double data, duplicate entry.
Exactly.
It's all one system.
That's exactly right.
Okay. And that's all the questions we have as of now.
Okay. Great. Well, I will keep on going.
Okay, you have more demo to do?
I do. I mean, I could keep on going for a while, but I don't want to, you know, overwhelm folks.
Yeah, we still have some time.
Yeah, good. And I mean, some of the questions can be interpreted a few different ways for what you're exactly trying to ask. So by all means, if I just answered those questions not adequately, then by all means follow up with me. So from here, I'm going to show you some example dashboards. So if I go down the left-hand side of this, I can click on dashboards, and we're seeing a set of canned dashboards. But the beauty of this is that you can go ahead and pick your own graphical representations of which measures you want on which dashboards, and go ahead and have them applied globally to your organization, or you can have them to yourselves. And I'll just show you a couple examples. So here's the cancer screening dashboard that I mentioned earlier, helped secure a grant for New York that was looking for breast cancer, cervical cancer, and colorectal cancer screening by location. So just a couple example graphical representations, as I mentioned. Here's the odometer with the results and the stoplight functionality applied over it. As I scroll down a little bit, we're seeing the screening trends for each of the cancer screening types, looking at it from 80% over to, well, it's about the same here, but you're seeing it over time with the stoplight functionality applied in the backdrop to make it just easy visually to understand where you are in terms of your goals. And as I scroll down even further, we're seeing breast cancer, cervical cancer, and colorectal cancer screening by location. So for each location, you can see, sorry for jumping around here, the result, the numerator, the denominator, and clicking on any of these to view the details is going to bring us right to the patient lists. Okay, so being able to identify the locations that you want within your organization for any of these types of measures, you can always get to the underlying measure detail, the underlying patient detail by clicking on the numbers that are hyperlinks. So that's an example cancer screening dashboard. I think, the other thing is able to navigate from the dashboards to the measure analyzer, for example. If I see colorectal cancer screening and I'm at 38%, and that's below my success criteria here, and I want to jump into seeing what's going on behind these numbers, I can click on colorectal cancer screening, and it's going to bring me right to the area that you'll find familiar because we just went through the drill down. But now this is, the colorectal cancer screening rather than diabetes eye exam, and I can start to sift through my data on this measure. So just helping you traverse very easily from the dashboards to the measure analyzer. I'll show you another example dashboard. This is the diabetes dashboard, so sort of staying in that same theme. We have the patients with diabetes, and it's just a count. So if I want to see all my diabetic patients, I can go ahead and click on this, and it's going to bring up that patient level detail. I can see A1C greater than 9 or untested over time. My controlled diabetics for A1C less than 7 within the current period and the stoplight odometer. I can see diabetics by A1C, so less than 7, between 7 and 8, between 8 and 9, patients with no A1C. We're certified for meaningful use CQMs, so we have the meaningful use diabetes scorecard here that can be extrapolated into the full set of measures. And then we're seeing uncontrolled diabetics by age. So fairly helpful, fairly comprehensive, and giving you a lot of different options for how you want to visualize the data and how you want to get down to that patient level detail at the appropriate time for your active outreach and engagement. The other dashboard that I'm going to show you here is our referral management dashboard. As I mentioned earlier, one component of the referral management reporting module was to have open referrals without a result in the patient visit planning report. This is the other piece to it, to have the dashboard with a variety of measures that represent the life cycle of the referral, from open, completed, canceled, deleted. Additionally, showing you stat referrals open greater than 7 days, urgent referrals open greater than 14 days, total referrals completed over time, open referrals completed by location, and open referrals completed by provider. We also have a referrals registry that will help you to track the entire life cycle across your entire patient population and pulling up the entire list of referrals that you have that are open. I will show you an example now of something that we find very, very exciting when it comes to the integration of payer data. So this is skipping around a little bit more towards the phase 2, but I think it's really important for everybody on the phone to understand the technology that's been built and ready to go as soon as we find some payers that will be willing to share some at least enrollment data and hopefully someday claims data to make you a lot more effective in your operations and how you respond to the attribution lists that are sent your way. So right here, I'm going to go ahead and click on plans. And we're seeing Community Health Plan, United Health Plan, and Group Health Plan. And what we can do is, now that we have your clinical data, because we just went through the standard, core implementation, we can start to ingest data from the plans. And we can take these attribution files from the plans and put all of it into one single comprehensive place for you to run reporting on. So if I want to look at Community Health Plan, I'll go ahead and update this. What this is showing is that for my health center, Community Health Plan has sent me an attribution list with 7,949 members, and 6,058 of them are unmatched, meaning 6,058 of them do not have data being collected because they're not patients that I'm actually seeing within my organization. Okay, and so what you want to do is understand who those members are. By clicking on this, it is going to immediately load the details for all of those members that have been attributed to you that you don't currently have data on, so that you can immediately start to form an outreach and engagement plan to pull those patients in and start to be able to engage in those managed care plans a lot more effectively. So we're seeing the timeline trend as well. Now, keep in mind, this is dummy data. We usually like to see between 70 and 90% match rate, meaning 70 to 90% of the members that are attributed to the health center being actually seen by the health center. But what this timeline trend can help you to do is see if it happens to trend downward, what just happened? Did you happen to get a whole additional set of members attributed to you that you were unaware of? And if so, now you are equipped to have a strong conversation or a conversation from a position of strength when you're talking to the plans. And at the very least, you can start to put together a plan around those newly attributed members that you need to reach out to. Continuing on this front, we grouped by a couple of different ways to help our clients as well. So grouping by age became a really successful criteria for our clients to understand who to reach out to, just by avoiding specific age ranges that maybe don't engage with the doctors. Certainly pediatrics and parents are a great place to start. Maybe not geriatrics, but that age range where chronic diseases start to form can also be a really effective area to start with that outreach. So what we've done is we've matched the members and grouped them by age so that you can find out exactly which age ranges and age criteria you want to reach out to, and who exactly within that age range is not a patient that you're seeing, but is an attributed member from the plan. As I scroll down a little further here, we're seeing matched members grouped by last encounter. Now, a lot of the managed care plans will insist that you're seeing your patients once a year. What this report is telling you is exactly who your patients are that have been in to see you within the last 2 years, but not within the last year. Because those are the highest likelihood of just needing to reach out to and have a little conversation around how to, remind them to come on back in for a visit. As I scroll over to the left a little bit further, or as I'm showing over to the left, matched members grouped by cost. Now, this is a little different because it's grouped by because it includes cost data. But if we can get that claims level detail from the payer, we've enabled this functionality to help you bucket your patients based on cost, or bucket the members based on cost, so that you can see, which buckets the members go into, so 0 to 5, 5 to 10, 10 to 25, so on and so forth. And furthermore, identify where those highest cost buckets are, where you have unmatched members that are costing the most, where primary care has effectiveness, right? So if you're looking at, initially we were looking at the 50 to 100 and 100 plus K category, but we found they were predominantly cancer patients, where unfortunately primary care doesn't have the most impact. So being able to find that cost threshold, where maybe it's the 5 to 10 or 10 to 25, where it's the hypertensive patients or the adult onset diabetics, where you can identify those unmatched members, or those members that have been attributed to you that you haven't seen, that have been costing the system the most, because that's potentially where you're getting dinged the hardest. So we have a lot of functionality around the integration of claims data, and I just wanted to make sure that that was noted as well. And if I look at sort of, payer integration, average cost per member per month, we are looking at the specific cost groups. So in this particular case, we're looking at 7 cost groups, from specialty, dental, labs, diagnostics, pharmaceutical, inpatient care, behavioral health, and unmapped. And the amount that each cost group represents for the entire organization. Being able to see the average cost per assigned member per month, the total cost, and members months. So this is pretty helpful overall. Again, continuing along the lines of payer integration, needing that actual payer claims line data to be able to provide this level of detail. And as with every other piece of functionality in the system, clicking on detail list will always pull up the underlying patient level detail for you to continue to dive into. I am sorry for the latency of the demo environment here, but it's basically going to pull up similarly what you've seen in all the other registries with a patient level detail. But this will have all the elements for those different cost categories and which one applies to each of the patients.
Hey, Chris, this is Brandy. We did actually have some questions come in, so just let me know when you're at a stopping point.
Yeah, no, I'm at a pretty good stopping point. Go ahead.
Okay. So I think one of these questions is based on, I guess, the level of organization. So the question was, is the software populating data from an organizational level or a clinic level?
Can you repeat that question? I'm trying to figure out what that means.
I think the question is, it's actually going to be both. I think it's based around, they're asking if the data is coming from an organizational level, so maybe like the parent community health center, or is it coming from each of the individual clinics? And I believe it's just an aggregated count, or it could be by health center. It just depends on how they want to look at the data.
Yeah, I mean, it's both. I mean, we're collecting the patient level detail at each of the locations, and that can be sliced and diced into either just an individual center and organization level. You can aggregate across the entire network. Really whatever you're trying to do is what the system is designed for. I think I don't know if that question may have been leaning more towards, like, would we be applying enrollment data from a single payer to an individual health center, or we would integrate data from a single payer to everyone in the network? And the answer is again, either. But I think it's much more effective if you run programs that enable payers to send us a single file on attributed members to all of the FQHCs so that we can turn this type of functionality on for everyone.
And then I think a compound question to what was just asked is really, is there a relationship between the Azara platform and information exchanges?
Currently in Louisiana, no, but we are doing a couple of projects with other network type entities that we could probably talk more about offline. The bottom line is HIEs look different in every place, but we do ingest data from them. If the HIE contains ADT data, if it contains claims data or enrollment data, all of the above, those are all the different data types that we can work with to integrate the functionality that I've shown you here. But yes, certainly going through an HIE is an excellent source of data should it be set up properly and contain data that people are comfortable with and confident in its accuracy.
And then the last question is based around kind of where does the front office staff fit into the development and implementation of the software?
Okay, yeah. So the implementation is an 8-week process where it's really meant to be of minimal impact to health center resources. We need a couple hours a week over that 8-week implementation process. We go through an iterative review cycle of our mapping documentation. And the resource that we need from that is one IT resource from your health center who's most familiar with the configuration of your EHR. That's how we begin the implementation process. Towards the end of the implementation process, we will need some time from the providers to go through data validation. And that's really to just make sure that we have accurate validated data, and then providers taking part and participating in the implementation of a technology always ends up in a higher level of usage and confidence in its accuracy as well. So, but really overall, it's important to know that all of that mapping is done by Azara resources, and it's about 300 hours of work that we do from a mapping standpoint and helping and facilitating adoption of the technology. So that's really it.
One last question was, some of the health centers may actually operate 2 separate EHR systems, one medical standpoint and then maybe some from a dental standpoint. So the question was, how is Azara integrated when there are potentially 2 separate EHR systems operating in the same health clinic?
That's probably more of a unique offline question based on the specific setup. I mean, a lot of our health centers that use different EHR and EDR systems have a common practice management system that we can pull from to give you at least the UDS and meaningful use dental related measures, or we can source the data directly from the dental system, but we can sort of cross that bridge when we get there.
And I think that's all the questions we have in the queue.
All right. Well, feel free to continue to chime in here. I'm going to just show a few other things within the system just to help folks understand a little bit more of the breadth of what we can access from a technical perspective. So I'm going to show an example registry, which is not incredibly exciting, but it is sort of important to see that despite having the hundreds of measures that we have in the system, we also wanted to give you the flexibility to dive into the registries as needed. So we have a list of canned registries out of the box from adult primary care, anticoagulation, asthma, depression, diabetes, hypertension, pain management, et cetera, et cetera. I'm just going to show you the example diabetes feature that we have in here for the registries. But this is also to say that you can create your own registries ad hoc and on the fly to get to the data that maybe we don't have in a perfect, measure format for you, or it's something that's particularly unique to your individual center. So we wanted to give the flexibility within these registries. You can see the same type of patient information can be accessed via the mouse over. The same type of information can be exported to Excel for any additional, Excel voodoo that that the user wants to do. But as I scroll over here, unlike what we saw earlier with the diabetes eye exam, this has a whole additional slew of columns that pertain to all diabetes-related measures. So most recent diagnosis date, A1C date, you can see the A1C results. You can also see how that correlates with LDL and blood pressure, foot exam, eye exam, et cetera, et cetera. So there are hundreds of data elements that we map during implementation. They are not limited to just what you can access within the measures, but also you'll be provided with the ability to generate your own registries ad hoc as you wish. I think if there's anything else in the dashboard that I wanted to go to. So I have some operational dashboards. So if I want to click on clinic operations, just giving you some nice ideas of just the number of visits. So your patient encounter count, and being able to slice and dice that in whichever way you want to from a productivity perspective, your number of active unique patients with a face-to-face encounter, your walk-ins, your panel size, patients with a qualifying encounter. We use the 4-cut methodology to empanel patients to providers. So that's a sort of national guideline that we use. If you have questions on it, ping me and I can give you a little more detail on it. Understanding your no-shows, and again, clicking on this will bring you to your patient details so you have a little bit more insight into your no-shows and your no-show trend. Provider continuity and patients being seen, patients seen by diagnosis. So I think, if I want to go into measures as well, I can go into operational measures. There are a series of operational and financial measures that we have as well. Some of them optional. A lot of them are in there as far as the core offering though. So we'll want to take a look through that as well and talk to you during the implementation just to make sure that we have everything configured and set up with the expectations of what you were, of what you wanted to get out of drives. So yeah, so I think, at that point, I'll open it up to questions. We have about, 10, 13 minutes left. More than happy to use it as you see fit, or we can give folks some of their day back.
Yeah, so we just have one last question that came in, and it pertains to some of the health centers may be in a transition phase between different EHR systems, so their data may actually be living in 2 separate places. So they're wondering, how does that data get integrated with the Azara platform?
Yeah, that'll also be a side conversation because it depends. Some EHRs are nicer than others about data migration. So it's not really cost effective to go through 2 implementations because you're trying to use our system as the reconciliator of data between the 2 systems, your legacy system and your new EHR. So I think we'll probably want to have that as a offline conversation to find out what the dominant strategy is given the circumstances and which EHRs are at play.
And then one other question, because you may or may not know this, but it says, from which health plans are you receiving data from? So I don't know if that's from maybe if Azara is working with individual health plans to integrate this type of platform with them.
No, I understand that question perfectly. I think that's really why we're doing this program, is to help equip you with that type of ingestion of data. But what it comes down to is the folks who are capable of giving the payers and the plans a nudge to get access to that data and engage at this level. That's where the PCA comes in, the HCCN. That's where all the centers come in. We've done this with a number of payers around the country, but this is a new launch of this type of project in Louisiana. So I think it's going to be very important for the HCCN to bring folks to the table and start to brainstorm about which payers are going to be targeted as the initial respondents to come to the table and engage in at least the enrollment integration. And we have some payers that are in other parts of the country that may give us a few ins to what's going on in Louisiana, but I think ultimately the folks who hold the power are and the ones who can move the meter on those discussions with the payers are likely to be the folks on the call today. So I'm definitely free to talk through any of those scenarios, but that's really a next phase that we're going to be working with in Louisiana, and we're excited about it. The technology is ready to go.
All right, Chris, that's all the questions that we have in queue. So I'll just give everyone one final chance to ask any questions that they may have, and then I just have some closing thoughts for us. So I'll give it like a minute or so.
Sure. And while you give that a minute, I'm going to pull up one more thing. So we have this report called the Care Gap Reconciliation Report that uses data that we'd be collecting from both the payers and the data that we're collecting from the EHR to reconcile any gaps that may be reported from one system or the other. So what I'm going to do is I'm going to go to January 2018. We're going to look at the measure for this as the colorectal cancer screening measure. We're going to update this list, this report. And what we're seeing is colorectal cancer screening that's member-based. Okay, we're seeing the matched members in this bucket over here. We're seeing the unmatched members over here. So the unmatched members aren't as exciting as the matched members because it's in this case that we can start to see what gaps in care or what colorectal cancer screening gaps are open in your EHR but are closed with the payer, and against vice versa. So what we're seeing is visits in the past year from your matched members. 162 is the number of gaps that the payer is reporting and the EHR is reporting as gaps for the same patients. Here we're seeing 232. That's where the payer is saying that it's an open gap and the EHR is saying it's closed. That's an administrative opportunity to have that closed up, as is where it is closed, or sorry, it's open by the payer and closed within your EHR. So you have the ability to just have that information delivered to the payer, receive credit for the work that you're doing, and then really have that be an administrative effort in closing those gaps. And it's been phenomenal to see what can be done in that percentage of gaps that may be in one system against the other. And if I want to just see, what is it that the payer considers open but the EHR considers closed, I can click on this number and it's going to bring me right to the details from that perspective of the payer. So yeah, these are sort of next level reports that we are doing with payer integration. But again, I just wanted to keep all this on everyone's radar today because there's a whole spectrum of sophistication from folks that are still needing some assistance with things like UDS to others who are really ready to operationalize some of this payer integration. And then of course, a lot of folks along, in between in that spectrum. So we're there and available to help you along the lines of, one part of the spectrum to the other. And of course, our partnership with the HCCN and PCA is going to make this even stronger.
All right, Chris, we don't have any other questions in the queue.
Okay. All right.
So I'll go ahead and take this opportunity to thank you, Chris, for giving us an hour and a half of your time. I know you're extremely busy. But just real quickly, I have two final closing thoughts that are really important for our health centers. So the question earlier was asked if they're already on Azara, what we actually need from them. So all those centers that have Azara implemented as a part of a partnership with LPHI or LSU, we do need a services agreement signed. And all those have been emailed to your CEO. So Those centers that are operating off of another partnership from Azara, we need to get that in order to integrate your data with the entire network. And then the final piece is we do want to let you know that we have set an internal deadline for receiving the contract documents to get our centers a part of the Azara. So March 30th has been assigned as like the drop dead date in order for our centers to get the contract documents, the services agreements, the BAAs, all that stuff to us. And those can be sent to Chris Obamfamois, and we'll get the needed signatures both on our part and Azara's piece. And I think that's all I have. Oh, and we will have follow-up calls for those centers that need additional assistance or have really center-specific questions for us. So definitely reach out to us, and we'll set up those calls. Reach out to Chris, and we'll get those calls set up and try to answer any questions that you may have that may be prohibiting you from signing the contract. But hopefully this webinar has really shown you the true value that Azara has to bring not only to your health center, but also to the network as a whole to help improve not only your workflows, but also your quality improvement pieces that we all strive for each year, and then ultimately improving your UDS measures each year. So with that, I will go ahead and close the webinar out. Again, any questions, please follow up with Chris Obamfamois, not Chris Neal. So with that, I'll go ahead and end the call. So thank you guys so much for joining.
Thank you.
Thanks, Chris.
Bye-bye.